I start? Okay. Good afternoon, everybody. Welcome to our 9th session of the Extension of Community Health Outcomes. Today is actually our last session of 2018 as we go into hibernation to prepare for 2019. We have been joined by Chipata, Chilenge, Nangongwe, and some people joining us individually include Dr. Sivile. There's Bill from Petauke. We have Esnat and Nefas from Japaigo. We acknowledge your presence. If you can hear us, may you please just wave? Okay, people who can hear us need to wave. Okay, so thank you very much. So we appreciate you joining us. The bigger the network, the better. Here at the hub, we are joined by the usual crew. We have people from ACOE, from the Pediatric Center of Excellence, and from the ID team. I see Lastina has just joined us. You are welcome. So without much ado, for the sake of time, we'll go straight into the presentation. Our presentation is talking about the HIV surge. How do we reach that last mile? With us, we have Dr. Mlenga, who's the care and treatment coordinator for HIV in Zambia. We'll have a didactic from him, then we'll move on to a case that's coming all the way from Chipata. This is the first time Chipata is presenting, so we're excited, though they submitted this case actually a month back. So we can go into the presentation.
Good afternoon, team. Wanted to look at the SAGE campaigns and how this may be the last piece which will be missing towards the HIV epidemic control.
Okay, so we'll have a look. We have 3 polling questions. I hope everybody can see those polling questions. So our first polling question, we hope everyone can see that. Which of the following are the high impact? Which of the following are the high impact activities for the HIV surge implementation? Is it case finding, linkage, retention, and viral load monitoring, HIV self-testing, and self-referral to facilities? So we have 5 people responding. Okay, 7 people. I must say, when I saw this question, I had to ask myself a bit. I think if you're not familiar with the surge, you may wonder why not HIV self-testing? Why not self-referral to clinics? But it seems most of our people think it's case finding, linkage, retention, and viral load monitoring, which sounds more like the HIV cascade. We'll go through those again. Okay, so our second polling question. Which of the following impact negatively on identifying the HIV positive individuals? Optimized PITC, suboptimal index testing, HIV self-testing. Whoa, that's fast. Okay, so we have 3 people. I know we had 7 before. So which ones are negative? Which ones don't help us identify our HIV positive individuals? Okay. Oh, wow, 11 people. So a lot of people feel that suboptimal index testing, but we have a few people that feel optimized provider-initiated testing and counseling negatively impacts us identifying. Some people also feel like HIV self-testing is not very helpful. I'm sure Dr. Mlenga will go into this as he does the presentation. So the third question, following the granular site management strategies to help us on maximizing case finding. So which of these help us maximize case finding? I hope everyone can see that question. So is it implementation of high-risk population screening, weekend after-hours testing, unnecessary retesting of people who are HIV negative? Okay. So which of the following help us to maximize? However, which one doesn't? Except, I hope we've all seen the except there. So we have 4 people that haven't answered from the original 11. Okay, remember there is the word except. I must say granular site management, Dr. Mlenga will go into this. This is where really you go to facility level and do a gap analysis based on activities, who's doing them. I did a lot of GSM in the past few weeks and I really enjoyed it. I find it to be very, very useful. Okay, so we have 10 people. I guess there's someone who has chosen to, okay, so there we go. So which one of these help us maximize? All these help us except one of these. So we're going to end the polling, and I'm sure Dr. Mlenga will go back to this when we reach the end. Okay.
So that's just the outline. We'll concentrate on reaching the last mile and the SAGE experience as well, a few slides on that. Just showing where we are, and most of the HIV burden is centered around our regions, and this is just a highlight. We are 12%. Again, the highest, as I presented the first session, is Lusaka, then followed by Western. And again, I need to emphasize, even though Western has a high prevalence, significantly, Lusaka is higher compared to Western province. Again, the viral load suppression is low at population level. Then the incidence, we have still the official figure we are reporting are 47,000 new cases. Globally, this is where we are for the 99 targets. We had 70, 77, and 82. I'm glad to say that Zambia is now above the global targets, which are there, at least we are above average. You can see, so we are 70.8, 86.9, and also 92% over the 90. And we have seen a huge surge in terms of ART initiation. As of this morning, we have 924,000 people on treatment, the current on treatment. And this is for Q3 2018. So as of end of September, we have 924,000 on treatment, which is good achievement. Now we still have a gap of almost 200,000 who are living with HIV. And for that, we need to see what do we have to do for us to reach this last mile. How do we reach there? So in doing that, we have to look at granular site management for precise ART impact. And in this, we need to look at one site at a time. When you're doing the GSM, we don't have to look at all the facilities at a go. It's one site at a time, where we have to focus on the limited number of the largest facilities. Again, each of the provinces, you need to look at those facilities which have a high burden. And instead of just partner management, you have to look more into site management. And this is what, as Dr. Foloshi mentioned, is what has been going on. Site level data is important to identify the problems that are generated and assigning responsibilities led by the Ministry of Health. And we need to have capacity building for QI and also shared responsibility. Now, in this, we have to identify the high impact activities. And the high impact activities, even from the polling, which you say, they are all linked around this. Case finding is very important, linkage, retention, and also viral load. And with this, we need a robust community health workforce. And this is in line with the ministry agenda for first to have a community promotion for all health services. And the recommendations, a number of recommendations which are given to the healthcare workers. We need to start with the limited number of sites. Those limited number of sites that we need to look at, as I said, is the large facilities. If we can maximize having the number of people on treatment in the large facilities, and in those large facilities, we give our targets not just 90, 90, 90, we go to 95, 95, 95, then we are going to have saturation for the whole program. Then we need to have also a combined and also collaborative relationship between the Ministry of Health, the donor, the partner, and also the site staff. And with this, you need to look at each site, how do we manage the patients as well. So we need a collaborative relationship for us to achieve this. And the leadership should be thoroughly involved. At each leadership, we recommend that we have a facility in charge, the head physicians, and in the physicians, we just need the head clinician. We need to have also the donor point person, the Ministry of Health, and also the paper partner. So each facility, we need to know who is in charge for us to know the leadership, how the leadership is moving forward. Another aspect is eFirst. So with eFirst, it would be better for us if we introduced eFirst in all the facilities. If we did that, then we are going to have better management and also better tracking of the various indicators that are set. We need to move from eLast to eFirst. And I'm sure we all understand what eLast and also eFirst do imply. The site level data is what is needed to be used, to be monitored, and also to evaluate performance. We do not have to look at provincial data or district data. It's each site, each of those identified high burden facilities. We need to look at the site level data, create with a dashboard, which you need to be reviewing regularly, and looking at which activities are doing well and those activities which are not doing well. So like this dashboard is showing us the facility, like in facility X, how many of those facilities have treatment new achievement, which is beyond 25%. And you can see that is the green, and also those colors are different, with the red one showing those facilities in red are doing poorly. This is important for us to know which facilities we need to concentrate on. And of course, you know, you have various tracking records, indicators for HIV positive, for treatment new, the linkages, and how many are we towards the 90/90 at facility level, and what is the achievement, and also the treatment current as well. So these ones are able to help us track where we are at each facility and see where we are lagging behind. Regular site visits recommendation number 5. So for us to do this GSM, we should visit these facilities regularly and also review the data. And this is also important for team building and also for having good relationship. And the tools that we need to use, they need to be standardized tools. And in all this, we need to be sure that what we are doing, the patient is central to this. And this is again a site activity matrix, an example where you need to look at each facility, where are we? So this is like presented in another way now. For go one of case finding, where are we in terms of on trending on partner notification services, index services, and you grade according to the color code, HIV testing, the universal routine HIV testing, and also the PITC uptake. And again, all these are key and they do not impact negatively on the HIV stage. So when you go to the polling station, the polling questions, you'll be able to at least identify which ones are the high impact activities which are needed. So this slide is very key. And it's not a polling station, by the way, it's a polling question. Eh? Then for sorry, we're having issues. Slides not moving.
Sorry. This one?
Next one. So another thing is, and I'm sure Dr. Sombo, you've been using this, including the mentors, is when you visit a site, you should include an action plan. A problem should be identified, what the cause is, the recommendation, who is responsible, with also a timeline. And the recommendation 7 is regular oversight again with accountability. The oversight should be done from the provincial director, the CDC directors, for those which are in the CDC regions, which is the 4 provinces we are concentrating on, and where all these facilities today we are tuned in, they're all coming from. And you need to have monthly meetings to review performance at each of these sites. What is important is to, when you start, you need to reassess and revise. What works in Lusaka is not going to work in Mongo, is not going to work in Sesheke or Chipata or Monze. So you need to review these data regularly and see what you need to do for you to improve the program. Now, this is the experience for the Lusaka. So when we started the Lusaka SAGE, we were targeting the saturation. We are looking really at the last 90 and also the second 90. And I'm glad to say that we have reached the last 90 and also the second 90 in Lusaka. And we did achieve that in 9 months of us starting the SAGE. It was launched on 1st December by His Excellency, the President of the Republic of Zambia. And with that, just highlighting a few things that we've seen is the fact that the number of contacts elicited per index patient increased in certain facilities. We had facilities where the index, we had 1.9 contacts index before, then that rose to 2.2 contacts per index, which was really, really good news, and also good data for us to rejoice with. Then also we found that TB gave the high yield as well in men. So we need again to identify which screening category, which screening we need to intensify, and which populations do we need to maximize on the screening. So the yield for TB, for HIV positive in those who are in the TB clinics, or those who are referred to clinics, is also high as well. Then treatment new through community initiation. Again, we had to see that there was a 10 times increase in the treatment new through the community aspects as well. And again, you can see that from February 18, we were at 35, then you can look to July 14, we were at 403. So this was, again, community aspect showed to the Lusaka SAGE that it's really a high modality for us to have a better yield. And the men has been, of course, very problematic. We need to find innovative ways of finding men. Of course, self-testing review. We are now talking of extended hours, weekend clinics to be opened as well, and also after 17 for the clinics to be open, and also pharmacies as well. Community linkages with the facilities, very key. As you saw, community performance was higher. We had a better yield in the community as compared to a facility. Then also site level QI to address issues systematically and also effectively. And we need to strengthen the mentorship. Just having numbers is not good enough. Our goal is to have HIV epidemic control, and with epidemic control, we need to have less number of new infections than the people that are dying. We can only have that if the quality is going. Keep an eye on the bigger picture. What is the impact? Are these activities sustainable? Are they cost efficient? And are we maximizing on the partnerships that we have with the various partners as government? With that, we can go to the polling questions.
Thank you very much, Dr. Mlenga. We'll start with the third one. So after that presentation, we can now see what we think. So which of these would help us not maximize in case finding, because there's an except. Which ones are not good in terms of case finding? Implementation of high-risk population screening, weekend and after-hours testing, and necessary retesting of HIV negatives. Oh, there we go. So we need at least 11 facilities to answer. And I know I've noticed the Wanika has joined us, Matero has joined us, Kalabo Mwena, which is actually Mongo, has joined us. The Wanika had a power problem, but they are back on. So we expect more than 11 respondents. Okay, so any comment on this one, Dr. Mlenga?
So it's good we have 100%. Again, you know, we said the high-risk populations, like we mentioned for TB, that gives a good yield. Extended hours, weekends, also the clinics being open. The retesting of HIV negatives does not give yields. If you've seen that even in UTH we have, and other facilities, we are giving color codes to those that already know their HIV status. So you're right, unnecessary retesting of HIV negatives does not give a better yield.
Mm-hmm. What about this one? Okay. Okay, which of the following impact negatively on identifying the HIV positive individuals? In other words, which one is not helpful when we are looking for people with HIV? Is it when you optimize your provider-initiated testing and counseling, suboptimal index testing, and HIV self-testing? Okay. Okay, any comment on that, Dr. Mlenga?
People are still polling, eh? We have 11. So HIV self-testing is an interesting one. A few weeks ago, there was something on air on HIV self-testing. And many people think that this may not be a game changer. However, what HIV self-testing does is to encourage someone who knows their status at their own time to have the courage to go for a screening test so that they can have a confirmatory test done as well. So HIV self-testing does not impact negatively in identifying the HIV positives. And this question, of course, is just about identification. Whether HIV self-testing does lead to the linkage is another question, or whether people are going to present themselves to facilities. but it does impact positively on identification of the HIV positives. Suboptimal index testing, of course, that is the answer, which should be, it impacts negatively on HIV positive individuals in terms of knowing their status.
Which of the following are the high impact activities for the HIV surge? The surge is the topic that Dr. Mlenga has talked about. Is it case finding, linkage to care, retention, and then viral load monitoring? Is it HIV self-testing and self-referral to facilities, meaning you wait for people to come? Okay, only 9, we need 11 minimum. Okay, 13. So which of these are high impact, Dr. Mlenga?
So the case finding, linkage, retention, and viral load, as 92% have indicated. All those, if you look in the matrix as well, those are the ones which are there. It's case finding, linkage, retention, and viral load monitoring. You may grade, of course, retention lower among the 4 of them. But self-referral to facilities, you're not actively involved into self-referral. So this does not impact to saturation. If we have to saturate the facilities with patients on ART, we don't have to rely on people just referring themselves.
Thank you very much, Dr. Mlenga. So why do we want to saturate facilities with ART?
Good question, Dr. Foloshi. We are now in a mode where we have to end HIV as a public health threat. For us to do that, we need to have less number of new infections. For us to have less number of new infections, we need to reduce the population level viral load. We can only reduce the population level viral load if those that are HIV infected are on treatment and they are suppressed. So we need anyone who is HIV positive to be identified and put on treatment. So in each region or each facility, their catchment area, you need to have an understanding of how many people they are who are living with HIV. And of those, how many people are living with HIV, how many of them are tested and how many of those are on treatment. Then that will give you now a gap, and you set your targets on how many of those. Of course, the targets usually is up to 95%. Of those that you have not covered, you reach them so that you can have the saturation. So it's all towards HIV epidemic control.
Okay, thank you very much, Dr. Mlenga. So as we give time to Chipata, please share your screen, Chipata, for the case. I'll give a chance to our community of practice, our network, if there are any comments or questions on the surge campaign. Any questions on the surge campaign? Okay, Nangongwe, please go ahead. Is that Mr. Mwape?
Can we get?
Yeah. Oh, hi, Dr. Mwape.
Hello.
Oh yes, please go ahead with your question.
Thank you so much, Dr. Mlenga, for the presentation. I have a question on the targets that are given to the facilities, especially the rural facilities. They seem to be having problems getting those targets achieved, and they've been asking what formula is used to get to these targets.
Issues of targets, interesting one. And unfortunately, you know, with targets, even when you set global targets, there are people at nations who feel no, those targets are not ideal. you set provincial targets. Also, the provinces feel that those targets are not ideal. You know, what we have is it's a best guess scenario which you have to implement. For HIV, we use a model which has various inputs. And in that model, we look at how many overtime patients do we expect have been seen. Then also how many new infections, depending on the studies which have been done, are also there. In this case, we really have been relying on Zambia, but the spectrum also has other indications as well. Those other indications for the spectrum are looking at how many people are moving in, how many people are also getting out, and how many people have been put on treatment. So there are various things that are put into the spectrum model for you to be able to know how many people that you have in a certain specified region living with HIV. And again, these numbers are just the best guess estimates which we have with the current data which is available. So from there, then you have to triangulate on how many are achievable, looking at the gap which you have. So they are not accurate, but they are numbers that we can deal with using the data that we have available.
Thank you very much. I think we need to pay compliments to our IT. Dr. Mwape, and the team are so clear, I can see Pezo. Any other questions from the network? Okay, Dr. Onoya, please go ahead. And after that, Mr. Ntula will get to you. We can't hear you.
Good afternoon.
Good afternoon.
Yeah, thank you for the presentation. But over the target, we've noticed that FY19 has just started, but there are facilities with new targets we found that have already achieved them. So I don't know if they are better targets or maybe they need to be reviewed.
So Philip, thank you for that. It's good that targets have been achieved in certain facilities. And what you're going to see is we have certain facilities which have like 100 and something achieving, meaning above what you really expect. And in looking at that is, we have certain facilities where if people move in, and I think one facility, let's say for Western Province is like Limulunga. Limulunga, we had a number of people moving into Limulunga, especially after realigning the districts, such that the targets which were there, they were achieved easily and they had more. And I think for Lusaka as well, we have seen in certain areas, I think Mount Makuru is also another facility which we had to see giving numbers which are higher. So again, you have to look at how many people are moving into each one of them, and that may lead to a higher figure. So when you are revising, like for the FY19 now, for people, some people out there, these are, we don't usually use this in government, but the US government usually uses, according to each year, their country operating plans. So like we are moving into planning for FY19. And as you do the FY19, it means what are we going to implement in the next year, which will start in October. So the targets are also being revised, and the targets will be set by January 19 for the US government. And those targets may be slightly different from the Zambian government targets. But again, what you need to know is how many people do we have moving in, and overachieving is a good as long as you can explain. But when you set your next targets, you don't have to be over-ambitious for you to set the targets according to the previous one. You have to be very realistic on what is happening on the ground.
I hope that was helpful, Dr. Onoya. And I know there are issues around the COP targets, the PEPFAR targets, but we always go for the target that's higher. And remember, there's a lot of science behind this. So that means that we should slow down. I know we were asked in Southern, what about for the non-SAGE facilities? What's the package for them? facilities are picked as a SAGE facility based on the amount of impact you get from them and the gap. So we expect to have a rollover effect to facilities that may not have the SAGE per se, but we know that the facilities picked are the ones that have the greatest need. So as for the targets, when you see that you're overachieving, I think there's no harm to reaching out to your partners and the IP, because sometimes we may actually have to look at them again. I know, Mr. Ntula, you had a question. Please go ahead.
Good afternoon. Thank you so much. I just have two quick questions. Or rather, the
please
first
introduce
one.
yourself. I'm sorry, please introduce yourself and where you're joining us from.
Thank you so much. My name is Ntula Simwinga. I'm joining you from the Historical Black Colleges and University Global Health Consortium right here within Lusaka. We are under American International Health Alliance.
Thank you.
All right. So thank you so much, Dr. Mlenga, for the beautiful presentation. My interest is when it comes to finding men, and also the results are evident to say the uptake of services is very good when it comes to HIV self-testing. And I've also been in several platforms where most recently it has shown that actually index testing is also helping us in terms of identifying partners of women, especially in the communities, local communities, the so-called compounds within Lusaka. Because when our counselors go there in the community, they find women in their houses, and usually they index, or maybe the clients who are elicited are their male partners who are identified. Now, I wanted to find out, is there a deliberate move or any approach which is going to be considered to merge or include HIV self-testing into index testing? Because we are seeing that the two approaches are actually helping to yield more results. I remain on that one. I don't have the specific data, but from the presentation, I can see that we are able to find men. But the other one, we are having challenges in terms of actually linking the HIV self-testing. But is there a way of including the HIV self-testing in index testing? Thank you, Doctor.
Thank you, Mr. Ntula. By that, do you mean if somebody comes in and they test positive, are these people now able to carry an HIV test back to their home and that partner, their partner self-test? Is that what you mean?
So what is happening right now, I remain to be corrected again, is that whatever implementing partner is implementing the HIV index testing, they're not using this HIV self-testing kits. They're using the, yes. So is there a way we can include the HIV self-testing kits instead of the ALEA or, the other tests into that guideline, into that system, so that we can modify the testing protocol within the index testing, but we have the HIV self-testing kits used instead? Because we can see that HIV self-testing, the uptake is very high, but we don't have much information on people who are reporting back. But is there a deliberate move we can have that integration?
Thank you, Ntula, for that. We will be revising in the coming year the whole testing panel. And use of the self-test kits is going to be revised to align with different concerns by those that have come from certain partners like the US government, where we have to use the antibody rapid testing cautiously, especially with the retestings, where we have found that we are using more and we are not getting the better yield, looking at the resources which are put in. So we are trying to see where best can we place the self-test kits. And you shouldn't, I'm just speculating, but you shouldn't be surprised if you see that even the self-test kits may be used also in facilities as well. When a client comes over, before they do the blood antibody test, you give them a kit. When they're seeing a clinician, by that time they would have done the self-testing as well. And of course, what you've mentioned as well in the index testing, pattern notification services as well, we're considering that. Now, I cannot confirm right now on where it's going to be placed, but we are thinking of maximizing on these self-testing kits. And also one thing is we are evaluating 2 more self-test kits so that we can have at least 3 platforms instead of relying on 1 platform. We feel that will be better way of using of the resources, and also not to be highly dependent on 1 source.
Okay. I hope that was helpful. So Chipata, please share your screen. If you have any questions from the network, please, we will still take them as we share the screen from Chipata. But I have a question. So how often should the HIV negatives test? As we were doing GSM, I noticed invariably, most of the facilities say that they test HIV negative people every 3 months.
So the HIV testing should be done every 3 months in a high-risk population. In the normal population, if someone tests negative, they just need to retest after 3 months for them to route, the issues of the window period. Otherwise, that retesting of every 3 months is not for every individual. It's in the high-risk populations.
Thank you very much. So there's something from the hub.
I wanted you to also put the figure in the normal population. Is it once a year, once every 2 years?
In the HIV negative population, in the HIV negative, yes. Who are non-high risk.
So all individuals are normal. So it's a normal, whether HIV positive or high risk or what, it's normal. However, for the one who is in a less risk category, those with a low risk category, we have not put a figure on how often they need to test. That should also be identified. If someone, let's say they haven't had any high risk exposure, then there would be no need for them to even recommend you should test every year. It's difficult, it depends on an individual. But for the high risk categories, because the risk is high, you need to have every 3 months. That's why you put a figure to that. For the other populations, we have not put any timeline.
But it's definitely not every 3 months.
No.
Okay, because we are now looking at the yield. I saw that the yield in TB patients is at 5%. I know I went to a market in Chawama where the yield was actually 50%. So those are the types of yields we want to be seeing. Something above 15% means that you are doing something very right with your index testing. When you are getting 1%, 2%, it means that we are either testing people who already know their status or too many HIV negatives. This is not to say that we are wishing HIV on people. It's just the science behind the epidemic. Please go ahead.
Yes, please. I wanted to ask concerning healthcare workers, because it's not everybody who gets a needle prick every 3 months, but most healthcare workers insist on testing every 3 months. Is it necessary?
In short, healthcare workers, high risk.
No, it's not necessary to have every 3 months test for healthcare workers. Again, it depends. Even when you classify the healthcare workers, there are people that don't have even any contact with bloods, but the healthcare workers. Just because you're in a health setting does not mean that you're in a high-risk category. So if you handle bloods, you do surgeries, of course you are in a high-risk category compared to those that handle blood. So no, we have not said that every 3 months every healthcare worker should have an HIV test. But if there's been an exposure, you need to have the HIV test, and that will be done at least first, then after 3 months.
Thank you very much.
Okay, thank you. So if a healthcare worker is in a high-risk situation, maybe discordant couple as well. So those are the issues. So Dr. Mlenga, we have a case for you, something you're very good at, from Chipata. Dr. Lusa and Olipa, are you ready? Hi, Dr. Lusa.
Yes, Doc, we are ready. The IT personnel can help us slide.
We have started.
We are using the UTH app IT.
Okay.
Yes, we are.
Please go ahead.
This is a case of a male 18 years old from Chipata Central ART Clinic. He was diagnosed with HIV in November 2009. By that time, he was 9 years old. And the initial regimen was abacavir, lamivudine, and nevirapine. This was in December 2009. Currently, the client is taking abacavir, lamivudine, and lopinavir boosted. In the past month, he has reported missing up to 5 doses. Grandmother and mother not too sure on how he takes the drugs. There is history of defaulting for more than 3 months in 2016. Currently, he is living between 2 homes. The father died from AIDS-related illness, and the mother is currently on ART. He is the firstborn, and the 3 other siblings are HIV negative. We can go to the next one. The clinical course of the client, in January 2018, he was reported with anemia, and between October 2017 and November 2018, he has required 6 blood transfusions for severe anemia. The lowest HB during this period was 3.3 grams per deciliter. He had no fever, no cough, no night sweat, but he's losing weight. We can go to the next. Next slide.
Dr. Lusa, please run through that slide.
Yes, please. This is the profile of the regimen the client has been on. At the initial state, he had abacavir 3TC NVP. Later on in 2010, he was switched on AZT 3TC NVP as second line. In 2010, due to failure, NVP was switched and he was on AZT DDL and lopinavir. In 2011, he had AZT 3TC lopinavir. DDL was dropped. In 2018, due to anemia, AZT was dropped. Now he's on abacavir 3TC and lopinavir. We can go to the next. Next slide, okay. This is the physical presentation of our client. His weight, the highest weight was 42.5. The latest as he came for review was 37, and this was on the 4th of December 2018. The height is 161.9, the BMI 16.4, the temperature is 36.3, pulse 1.6, the respiration 20, the BP is 90/60. That is just an error, 90/60 of blood pressure. Next. These have been the labs from the time the client started. The CD4 at start was 20, the HB 8 in 2010, HB 9, 9.9, CD4 36, which peaked in 2012 to 623. In 2013, it peaked up to 900, but in December, the CD4 dropped up to 0.2. And on the other hand, that is the profile of HB, 8, 9, 11, and in 2013, that was 10.3. On the other side, we have the profile of viral loads. The first one was done in 2017. That is January, and the viral load was 999,679 copies per mil. In May 2017, the viral load was repeated, and the reading is 347,874 copies per mil. And recently, in December 2017, the viral load is 218,898 copies per mil. The latest viral loads done in November is 127,777 copies per mil. The CD4 is unrecordable, and the HB is 5.0. Besides this, the gene expert is negative, LT 32.9 millimoles per liter, creatinine 38 micromole per liter, and awaiting genotype, samples have been collected to be taken to Lusaka. This is the biological profile. Now our question, considering the persistent anemia and questionable adherence and probable resistance, what would be the next appropriate course of management? This is our question. Thank you.
Thank you very much, Dr. Lusa. I'm sure there are a lot of questions. I will say from the networks, because I'm already feeling pressure here in the hub. Let me summarize that again. So we have a 9-year-old a male. He's now an adolescent, because now he's actually 18 years old, likely congenital HIV, started ART in 2009. His first regimen was a backup with nevirapine. To cut the long and short is now is on a Bacava 3TC lopinivir. Previous exposure involves AZT, switched because he developed anemia. Didanosine switched because there was a programmatic switch. We stopped using didanosine in Zambia, and seems to actually have done well. Started off with a CD4 of 20, which actually peaked to almost 1,000 in 2013. Then you see a gradual drop. I think you see the same pattern with his viral load. All of them are done in 2018, really dropping from 319, going up and down. Anyway, I think periods of adherence, non-adherence at some point. And unfortunately, his clinical course has been complicated by an anemia. Etiology is not very clear because the team dropped the AZT, but he continues to have a low HB. So we don't know why he has anemia, but they went ahead and tested for TB, reasonably enough, and they found actually he doesn't have TB. This facility, if you count the number of genotypes they've done 3 genotypes over the course of 1 year. And you can see, yes, I know Dr. Lusa said 8448 was an error, but you can see his BMI is actually very low. So he's not doing well. So what do they do in this instance where they've been waiting for a viral load for quite long? He has anemia. He's clearly failing treatment. We don't know it's because of adherence or not. What would be best for this patient in this situation? So from the networks, I know I can see Chimunya. I love these TVs. I can see people very clearly. Yes. So Chimunya, please go ahead with your question. Sorry, Chimunya, we can't hear you.
Oh, you're getting me now?
Yes.
Thank you very much. This case is very, very interesting. And I can see that the staff at the clinic or the clinicians who are attending to these patients really tried their best, and they're trying their best to take care of our patient. But what I'm
speak up, my dear. Speak up.
What I'm saying is, I think the clinicians at the facility are trying their best to take care of the patient, and they've done quite a good job. But what I'm seeing is that I think there are patient factors here that are involved. The patient is quite unstable. I was thinking probably they could have taken more information on his social factors like sexual partners, because he's already 18, and also his drinking habits. Does he take any alcohol? Any alcohol, history of alcohol and sexual history?
Thank you very much, Chimunya. Do we have any more questions from the network? I see a question from Nangongwe. Please go ahead.
Thank you very much. I'm Nathan Sinyangwe. I'm from Nangongwe. My question is, to what extent the family-centered approach has been looking at the social factors already mentioned, that already this child is living between 2 homes, which means the issue of adherence there comes in. This could also be one of the causes of anemia, as already explained, as you've already said, Dr. Sombo, that the etiology for the anemia is not known. It could be iron deficient, so maybe the nutritional factors could be issues that may bring this issue of anemia. So basically the question is, to what extent the family's been involved, bearing in mind that this child is living between two homes, and that's also how issues of adherence have been handled. Thank you.
Hello? Sorry, Dr. Lusa.
Are you getting us?
Yes, very well.
Okay.
So both families have been involved. That is the paternal grandmother and the biological mother, and even two aunties from the paternal side.
So Olipa,
we probed. Yes, Doc.
Yes,
we
sorry.
Go
ahead.
Yes, we probed further from the aunties and even the grandmother. Yes, drinking habits could be there because the boy said, on Christmas, I do drink. But on girlfriends, when we probed, he just mentioned, I have a girlfriend, but I don't sleep with any of them. So both families are involved, actually. We are interacting with the aunties and the mother. Seems the grandmother seems to be more concerned over the boy than the biological mother.
Thank you, Olipa. So in short, you are saying that really there's been a lot of family involvement, but this child seems to be deteriorating. Thank you, Olipa. Any other questions from the network? Before I move on to the Lewanika, oh, sorry, actually I saw that. Sorry, I missed that. Lewanika, please go ahead.
Hello, you can hear that?
Yes, Howard, please go ahead.
May ever consider being a secret case? Any medical test, like maybe sickle cell follows, which is those who have got HIV, the trigger for this. That matter, we think of because secret case, looking at the age of the child, and also to consider the range of malone.
But could it be sickle cell?
Dr. Lusa.
Yes. Though we don't have a formal result which was certain that the boy is not a sickler, but it has been ruled out. He's not a sickle cell patient.
Okay. So I think the point that Dr. Howard is trying to make is that when you have an anemia, you really need to chase the etiology. I think at this point we see that he actually just had sudden drop over the past 1 year to 2 years. So it's not like it started from childhood, but I think it's really worthwhile. We have made a diagnosis of anemia of sickle cell in a pregnant woman. So I think that's a very good question, Dr. Howard, and that Dr. Lusa, you've looked into that. So people are interested, and I know Chilengi has sent in a question. What type of anemia are we talking about? I think it's actually a pancytopenia, microcytic hypochromic. When I looked at the picture, I tried to take a picture, but it was a bit faded. But all the bloodlines are down with a bit of microcytic anemia. I think we have a comment from the hub.
Actually, you've answered my question.
Oh, wow. I'm becoming good at this. Okay. So, yeah, there are issues about the anemia that we need to chase it further, isn't it, Dr. Mlenga? Any more comments from our network? Someone is saying it would have been nice to see what regime was going on alongside with the viral load when you are seeing these high and low viral loads, what regime the child was on. I know Dr. Mlenga is looking at a picture of the full blood count, so you'll be able to comment on that further. But it looks like this viral load has been down, even on their back of arthritis, has been high, even on their back of arthritis in Opiniva. Previously, they were only using a CD4 count and seems to have done better. Anything else from our networks? Material level 1, please go ahead. We have a lot of mentors in material today. Yes, Aaron. Aaron, Judith, and Chivangu, please go ahead. We can hear you actually very well.
Okay, my name is Miriam Nachinga. Yes, my question was, how was the disclosure from the time the child started the medication up?
So, thank you for that question. Aaron, please repeat that question because you are nearer to the speaker.
The question is, at what age was the disclosure done? We're trying to look at the aspect that maybe this is what might have led to the poor adherence issues.
Hi, Olipa, did you hear that?
No, let him come again.
How was the disclosure done and at what age was it done? The concern is that the patient is probably non-adherent because disclosure has either not been done or it wasn't done properly. Do you have any idea?
Yes. On the disclosure part, actually it's true. The client was 9 years old when the diagnosis of HIV was made. And at that time, the treatment was started and disclosure was not done. It's not really clear from the file that disclosure fully done. But up to somewhere 2016, we still see disclosure counseling going on, meaning it's too long for the client to be disclosed to. At the same time, I can also answer on the issue of adherence. This client started treatment when he was 9 years old, but already a year later, there were issues of meeting dosage. Then in 2010, the client was switched to second line. Still, the disclosure was not yet done at that time. But at least with time counseling going on, the client became adherent to treatment till at a certain time when the father died. That's when now it became worse. Even the issue of defaulting came in later. But I agree, we had issues to do with disclosure in this client. Thank you.
Thank you, Dr. Lusa. I see the file you have there is actually quite, it's quite big, isn't it? So not a very history to put together, but I know, Olipa, you did a very good job. I don't think it's an easy case, but we have a comment from Dr. Onoya who says that he personally thinks that resistance testing is very important, which is actually what you showed by doing 3 resistance tests over 1 year. Okay, so he thinks it's very important, and he thinks that gene expert, you can't rule out TB by just one gene expert. So he says, start the patient on TB treatment, and then rule out the unconventional use of HIV treatment. I'm not sure what that means, but yes, so he feels it's still TB. I don't know if we have any comments from the hub. Dr. Siko, any thoughts? I thought I saw Dr. Suwilanji. Is Dr. Suwi there? Any thoughts? This is your bread and butter.
I start?
Yeah.
So I think I agree with. Okay, Dr. Sivile, you can go ahead.
Hi, Sombo. Hi, Doc. Good afternoon, Dr. Malenga.
Hi, Doc.
Yes, I am in Mukoni village doing index testing.
Wow.
Don't forget to index
And I've just found a 5-year-old positive through index testing.
Wow.
Oh,
well done. Although, yeah.
So I will recommend it highly I know our guidelines, it doesn't come out so strong, but I recommend that probably as we review them, index testing should be so strong. It's a powerful tool that we need to emphasize on.
Thank you, Dr.
So concerning the patient, yeah, I agree that maybe we need to know the cause of the anemia, and it would be nice if we can know what the hemogram indices say. Yeah, and issues of counseling, they are also important. I agree as well. Issues of TB, probably of the idea, I haven't heard of the indices, but I'm of the idea that this patient maybe doesn't have TB. The test seems okay. Yeah, it was negative, and that anemia has been there for quite some time, over 2 years. I'm wondering if TB can persist for that long without, causing bad things like mortality. I think that the anemia is because of the viremia, the high viremia that has persisted, as we can see from the viral load. There's I think I've heard of HIV-associated anemia. That viral load has been high for the last 2 years or so. So I think effective therapy, ART would probably sort out that anemia. But knowing the hemogram, the indices on the hemogram were very helpful. So in my opinion, I think TB, probably we can rule it. We can safely say that this is not TB, and the anemia might be just HIV-associated anemia. Knowing, after I've heard that probably the patient had a pancytopenia. In places where they're able to handle the case, probably they can do, iron tests, serum, iron ferritin, bone marrow, aspiration and things like that. But probably I would probably lean on changing the ART regimen to something that's effective. I think it will help with anemia. Thank you very much.
Thank you very much, Dr. CV, and well done for finding that child. I think it goes back to say, remember, we need to index the biological children of women that are found with HIV. Maybe if we were stronger in the past, we would have caught it a bit earlier. On the tuberculosis, I know Dr. Zico kind of agreed with Dr. Onoya when he said, let's start the ATT. So it would be interesting to hear his thoughts.
I wasn't of the idea that we start the ATT, but I also agree that we may not completely rule out TB in the patient. It may not be entirely responsible for the anemia throughout the period, but it would have come in at some point during the course of the disease. And at this age of 18, I don't think it would be a bad idea to do a urine lamp, because we may be dealing with extrapulmonary TB. And it would also be good if we knew if there was any lymph node somewhere that we could biopsy. That would also give us an idea of what would be happening in this child. I agree with Dr. Sevilla about the change of ART, but we also have an issue of adherence in this patient, which needs to be dealt with appropriately before that change of ART can actually be effective in the patient.
Okay, so interesting thoughts. I know that Dr. Zulu is with the Chipata team, so I think the suggestion that people look for any lymph node in case they can biopsy something that can help us with this anemia. Any more thoughts from our team in the hub? Before we turn to Dr. Mlenga to comment on that, I know we have talked about adherence, but when I look at that pill burden in an adolescent, I always have to raise my eyebrows. And I know we're talking about effective ART, and this is 1 year down the line. I'm not sure what would have been best to do so that we are not waiting for a genotype 1 year later, what ART we can use. But I think the other thing we overlook is, I think, the constraints that Olipa and team had in the switching of ARPs. There's a lot of sequential monotherapy, so there's a bit of a limping, then they pick up, they have AZT, they switch. So I think there was also a struggle with the drugs. I don't know, Dr. Mlenga, if you want to comment on this case now. I know you looked at the indices, so people maybe want you to comment on those.
Thank you, Chipata. Olipa, how are you?
Unmute her.
Oh. I'm fine, doctor. How are you?
We are limping.
Come and limp with us in Chipata.
Very soon I'm coming to join you. I would like to...
You are welcome.
I think first congratulate you people on the ground for the job well done. This is a complex patient. And I think some of the things that have happened to this young boy may not be entirely because the young boy has not been taking treatment. But I think even, especially as clinicians, maybe we could have done some jobs better for us to prevent reaching where we are. I think the two issues which we need to answer is this anemia, what is causing the anemia? And when I looked at the indices, the white cell is low, red cell is low. I didn't see the neutrophils there. The HB, of course, is low. The only thing is that the platelet was also quite high. Could this patient may have bled at one time? The platelet was at 543. Or are we looking at the lymphoproliferative disorder as well? But all in all, I think this may be related to either the chronic infection of HIV or maybe the TB itself, which we cannot rule out completely. Or are we dealing with an atypical mycobacteria as well? The CD4 is very low. I've not heard of any GE issues, any diarrhea issues as well. Again, MAC is one consideration which you can give in this patient. And in such a way, in fact, I'm sure you've done the peripheral smears, but the bone marrow culture would be important as well. And also, if we can do just the bone marrow aspirate, I think that may give us a clear picture. But as long as we do not control the HIV, we cannot explicitly say that there is another thing which is causing this anemia. HIV has to be controlled. We started this client on ABC3TC NVP in 2009. Then we changed this patient to AZT3TC NVP. I think, doctor, I may have heard that this was because of failure. If we switched because of failure at that time, I think that's where we started missing it. Because if we switched, we knew this patient was on ABC3TC NVP, then we changed to AZT3TC NVP. If this patient was failing, I think we can all agree that 3TC was gone by this time, was the first drug to have gone. NVP was the second drug to have gone. Then when we gave AZT, possibly AZT was still active, we gave a monotherapy of AZT. Then again, we tried to change to DDI and the PI, maintained AZT. Again, here AZT could have failed because it was the only drug available. So when we are adding the DDI, which we did not give, and you know, with AZT failure and DDI, likely there were times and DDI could not have worked even then. So it's like we introduced just the lopinavir also as a monotherapy, even when we introduced the 3TC in place of DDI. Then again, we went back to ABC, which had failed. And of course, our faithful amivudine on board as well. Then with the lopinavir. So I think right now, I'm glad I think Dr. Foloshi's case may have been attended to already. I think at this time where we have this information, the patient was taking 0 drugs. And in my opinion, I wouldn't force this child to take any more drugs. With a CD4 of 0, and we're giving ABC3TC lopinavir, and it's been failing for a long, long time, I think it was going even to be good to just say, okay, stop the drugs, then let's work out your case and see what the next stages are. I think, friends, at times it's very good to realize especially even when a patient, another indication for stopping therapy is when a patient cannot respond to the treatment which you have, or the patient cannot adhere to therapy despite adherence. I'm sure the ID people, Dr. Zulu there, would point to the fact that sometimes we give even the 3TC as a monotherapy, because we know in this case 3TC was gone, you just want to weaken the virus, you can maintain it. But at this time, I'm not surprised we had a CD4 of 0 because the ART was not working. And as a result, we don't expect the bone marrow to regenerate. We may have the virus sitting there, and you know the virus itself can cause white cell series, or it can cause a pancytopenia HIV on its own, or it can cause just a certain series. And just as well, AZT as well can cause just in fact, if it was AZT, I would have expected even the platelets to be low, doctor. So I don't think that this may have been AZT induced. I think it could have been the virus, which we have not been adequately addressed. I also need to apologize not to come in. We have had issues, but I think right now we have, I wish the lab was here, we have kicked up with the genotyping. We are seeing results even in 3 weeks' time or so, the turnaround time. And it would be good to go back to all these genotypes which are done, because I'm sure the samples, if you sent to UTH, they're there. They haven't been processed yet. Yeah. So we can quicken this process and look at the resistance pattern. It would be glad, Dr. Folosh, if we can have another follow-up once we know the genotyping. So blindly, maybe the question is, what do we do now, or what has been done? Now, it's very difficult to argue with Dr. Folosh's decisions. Dr. Folosh started TLD with atazanavir, ritonavir. It's difficult to argue with Dr. Folosh. Tenofovir is going to, of course, may work, but we have DTG and we have atazanavir there. If I were in Dr. Folosh's shoes, I would have added the darunavir.
Chipata.
Yes, send to Chipata. The same way this morning we were able to send to Bauleni. But I mean, these are decisions which I think for now this is good. But if we are able to intensify, maybe atazanavir may be replaced by the darunavir if we are able to send.
Okay, is that helpful, Dr. Luz? I know you have Dr. Zulu there. So I think the consensus is, I know there have been issues of adherence. And for me, when I hear adherence in an 18-year-old, I'm just thinking pill burden. I like this regime because it's only 2 tablets. Of course, dolutegravir is very strong. We don't know how strong atazanavir is. And we kind of looked at what they had, which was TLD and atazanavir. But that said, I think we at this point, because there's 1 year of wait, just waiting for effective ART, and we think this child is like this because all they need is likely effective ART. So we will send you a stronger PI, maybe darunavir, to add to this regime. But we'll receive the sample you sent. You're sending one to ICAP. We'll genotype that,
yes.
and we'll modify the regime to what is simplest for him. Because I know lopinavir may be 4 tablets a day or whatever, but you need to be investigated better. I think maybe Dr. Zulu can see the patient since he's there for third-line services. Yeah, I think for now, that's what we'll do. And when the genotype comes in, we'll treat it as agent, so you have it within 1 week, isn't it? Within 2 weeks. We'll be able to give you a result, and maybe we can present this case a bit later. But I think, as people have said, sometimes you end up stopping ART if someone is not adherent. So you actually have to deal with the adherence issues, the home issues. He's staying between 2 homes. I don't know, Dr. Lusa, what you think?
Last time we talked to the grandmother, she said she will look after the boy. She won't allow him to go to the mother.
Yeah. I think that is important. And also maybe you have to emphasize to the boy that right now the drugs may change, because when we get and we are going to sequence, even including all those which you've sent earlier, because the patterns may be changing. You've been sending at different times and with these different switches. There are certain mutations which may not be seen right now. So you need to have the confidence of the boy that maybe there may be a number of maybe 3-4 switches to be done. He has to understand that all those switches, it's based on the information which you have currently. So if we have any new information from the results, you may have to switch. And there's no shame in agreeing that, that right now this is what we have, and depending on new information, if it comes up, we may be able to change so that we can give the best regime to this boy.
Okay, so you have a comment from Chilenge. They are saying they're agreeing with you that, of course, controlling the viral load is very important. But what is the priority in the management of this patient at this stage? Is it controlling the viral load with effective therapy, or ruling out an OI like MAC, or determining the cause of the anemia?
Excellent question. This patient doesn't have to do one thing and you leave the other. If you don't have put this patient on effective ART, this patient is going to develop more OIs. In fact, right now, I don't think there is an opportunistic infection. Right now, we are only dealing with anemia. The HIV, if you don't control it, you're not going to control the anemia. So as you are investigating for the cause of the anemia, which of course will be, from what we have said, is urine lamp. I think I agree, you need to do that. The chest X-ray, I'm sure you reviewed Dr. Zulu and the team there, Dr. O. You need to subject those, check for anywhere lymph nodes, do ultrasounds as well, because at times it could be in the abdomen. That's where you have issues. And again, if we can do bone marrow as well, if you can do blood culture for now, I don't know if you're able to do blood culture for MAC. To me, MAC should also be top on the list as well. And they have the peripheral smear done as well. So as you're looking at the anemia, the first thing to me is control the HIV. You don't control the HIV now, you're not going to control the anemia. So the question from Mongo over finding the cause, anemia again is a problematic thing. We have patients where we have had maybe 6-7 months or even a year, we don't have a diagnosis for the cause of the anemia. But in this one, if you don't control the HIV, the anemia is not going to be controlled. So we have to do all things at a go.
I see Sister Mundende, you are also there in Chipata. We miss you here. So thank you very much, Dr. Mlenga, on that. So for now, the patient is on TLD and Atazanava, and maybe we need to strengthen the regime with maybe Darunava. I've always thought that Chilenge is the hotspot, but I've seen a very interesting question from Mongu, but I'll get to you. Let me just deal with Dr. Sivile, who has raised his hand. Dr. Sivile, please go ahead.
I think, yes, so mine was just to agree with Dr. Mulenga. There are other things in this patient that probably suggest that there's no OI, like he's mentioned. Yeah, while I agree that those OIs are possible, but the likelihood is a bit lower. If you notice that the AST in this patient is normal. So commonly, if you have bone marrow involvement, bowel involvement, chest involvement, you'll find that AST will be shooting up. So that can give us a bit of comfort, apart from just the history, that the bad OIs might not be there. So switching the ART to the current regime, to the suggested regimen, is probably the best thing we can ever do for this patient. Yeah, in view of that very low CD4 count, which cannot even be detected, I guess issues of prophylaxis is the other issues that probably we might need to discuss.
Thank you very much, Dr. TV. But I know, Chipata, we are with Dr. Zulu and Sister Mundende. I don't know, what's your comment, Dr. Zulu, on empiric third line switches, which is essentially sort of what we had to do because of we've really delayed this genotype. Any comment on when are we allowed to do this? Is it good practice? Is this a best practice, switching empirically to a third line regimen?
So switching to empiric third line can be very useful if the history is well taken. So like looking at the history of this patient, you have a lot of sequential monotherapy and looking at the drugs that they are on. But maybe I'll mention quickly on a few drugs. For example, patients that have been exposed to drugs like efavirenz, you know that efavirenz usually will select for certain mutations that could allow the use of, let's say, travarin for third line as a third line drug, while those that use nevirapine as a first line drug might not have the use of travarin later on. So looking at the history of what the patient was on is also very important. Looking at the file for these patients, there are a number of things, and of course we'll discuss with the team later. Even just the blood picture, like I'll agree with Dr. Sevilla. One of the other things you notice is the patient has a raised RDW, that's the red cell distribution, which shows that they probably have a mixed picture, more of a microcytosis and macrocytosis at the same time. So that could mean the drug could have had some effect, the HIV could have had also some effect. So following up a lot of the things will need to be done for this patient. So just conclude empiric third line. So it can be useful with a very good history taken. If not, I would rather switch to 3TC monotherapy while waiting to get a better history and follow up a genotype than rushing to third line.
Thank you very much, Dr. Zulu, for that contribution, that we should not rush to third line, especially when you have adherence issues. But sometimes you are caught between a rock and a hard place, you know. I think the conclusion is this child needs effective ART. So sometimes you may have to make decisions that are a bit difficult to follow up. So Lusa and Olipa, any questions on your patient? I think we've acknowledged not very easy, but we can still do something for the patient.
I think for now it's okay. We'll wait for the Runavia while waiting also for the genotype resistant test results.
Okay, thank you very much, Dr. Lusa, but we'll still wait for that genotype that our IP is sending in, isn't it? And we'll run whatever we have in the lab.
Yes.
Then we can co-manage the patient. So Dr. Mlenga, there's a closing question for you here from Mogu Urban. So I see we've got another hotspot aside Chilenje. Dr. Simenda, I see you've joined us. You are welcome. I hope you can hear us. So since they introduced self-testing, if a person tests himself or herself, and then they found that they're HIV, then in the process they commit suicide, who will be responsible for that death? Is the question from Mogu. They want to know.
The ones who is responsible is the person. I know there's a hotline for counseling. I've just forgotten. I think we'll distribute that number. When someone does the self-test for HIV, where they can reach out in case they need counseling, and even before doing it, they can reach out to that number. But even now, we are thinking of even extending that 70-40 hotline for maybe to work 24 hours, the UTH hotline, where people can have access to someone who can talk them through issues which they may have after self-testing. However, if someone does commit suicide, really it's not that the health worker is the one who has caused that. It's that there were other issues and they could not tolerate it. Sorry, Mongo. You won't be responsible if you distributed the kits.
Okay, so there we are. And of course, with appropriate counseling as we distribute the kits, that HIV is not a life sentence. People with HIV can live as long as someone without HIV, especially with drugs like, as was described, the beautiful drug dolutegravir. So we can have people living much, much longer. So we really don't expect people to commit suicide. But if it happens, that's very unfortunate, but no one will be held liable for that, because the fact that somebody agrees to get a self-kit, it means that somehow they are prepared. So I think with that, Olipa and Lusa, thank you very much for leading us through this case of quite a complex patient, but they are there, and we want to manage them together. And if there are any issues, let's call 70-40. So in closing, we are going on a 1-month hibernation. Our next session will be on the 21st of January. It's likely to be EMTCT or maybe PrEP or viral load or failure or treatment failure. However, on the 14th of January, there will be IT sessions just to make sure that we are all looking good, we can all hear each other, we all know how to raise our hands and use the chat box. So the one leading that session will be Chatonda, but we'll see everybody on the 21st of January. And thank you so much for making ECHO a success in 2018. Thank you.
One more quick announcement. If you may kindly send your attendance registers as soon as you can. Thank you.
Thank you so much. Thank you so much. Thanks.
Thank you. Happy